Got nothing?
So yeah, it's pretty, it's only in the system.
Get a bellyache because we didn't pray before we ate.
Mhm.
The roll call. No, I'm a Hindu. Roll call, we're all three here and everybody, thank you for coming. So pray with us real quick, and then we'll get back to it.
Heavenly Father, we continue to give you thanks, Lord, for all you do for us. We ask, Father, your blessing upon this time we have together in this meeting today, and we ask in Jesus' name. Amen.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Yeah. Well, before we get started, do we have any citizens? Let's go on. You guys have the floor. Thank you. And brought lunch. I appreciate that.
Absolutely, we appreciate the time today.
You bet.
For those of you who I have not met, I think almost everybody now, my name is Caitlin Hinman and I'm with Hub International. And we help municipalities and private businesses on their employee benefits program. So today, the reason we're here is to talk about the Blue Cross plan through OPEH&W and what it would look like to go direct to Blue Cross. So as you are all aware, those assessments have come your way and most municipalities are looking to get out. So we feel like those will continue to come. The Blue Cross Blue Shield as an organization is geared up to help take over the counties, municipalities and other groups that are on there to have a soft landing when you get off of that platform and transfer over. So.
I'm Tony Shalom, the regional executive for the Employee Benefits Division. I'm in Oklahoma, Arkansas, so I'm here for complete support and support of Caitlin and her team as well. And just to be a liaison for any kind of event you guys need in Oklahoma.
Tim Johnson, County Executive. I'm the person who's over our service team that would be assisting with day-to-day. I'm also part of the assistance with the strategy, the renewal preparation, claims, experience, review, all that stuff. So, glad to be here.
We're very appreciative of Melanie. We've been working with her over the past half a year to understand more about your employees and your group and what Melanie needs to be able to do a good job to help her employees when they need it. So not only are we going to talk about placing your insurance, but also after that, working with Melanie so that your employees get an enhanced level of service. So, and those are all things that she's aware of, and I know we said that in that meeting too. But those are all just as important as a number, we feel like. Yes. Yes. So just to kind of start off, Blue Cross Blue Shield, they have different networks. They have most employers in the state of Oklahoma are on Advantage Network. So in the state, the footprint of the state, Advantage Network is very robust. We don't really have any issues except for one place, and that's called Stillwater Medical. That's the one that is a thorn in the side that doesn't allow groups to just easily go to Advantage if your employees are in the area where they're going to Stillwater Medical. The difference between the cost of choosing Advantage Network versus choice is very large, as you will see. So a lot of private businesses outside of OPH&W or counties and cities that have come off, if they have employees that's going to be an issue for, they can actually do a dual option. They can say for the employees, we have businesses that'll have, an Oklahoma City office, Stillwater office, a Perry office, an Enid office, as I was telling you. So they'll do a Stillwater only plan and then all others for those that it's important for, or that, is non-negotiable. You'll see the rate difference. The benefits are identical, but the price to go to Stillwater is a lot more on the sheet than to have all others. So just keep that in mind as we go through this. With OPH&W, you all are paying that higher rate on that choice network is what they call it. That's all that Stillwater will partner with. So as we go through this, when you look at that cost, that's something we wanted to talk through is we can have two plans with the same benefit, Stillwater and non. We're going to skip that very first page. We're going to talk about that first page is we're going to get back to that. The benefits start on the following page. At the top, it looks like this. That very first page, it says OPEH&W current diamond source. That is what they call your plan. So Blue Cross Blue Shield, since you're just moving from on that platform to direct, they have all of your claims, they have all of your data, they know all of who your employees were once we got to send that to them. So they looked at what plans they have going direct to Blue Cross that would closely mirror what you have today. So as you'll see, if we go through that very first column, current diamond choice, we'll go over what your plan looks like today. So for an individual, you have a $1,000 deductible, and we're gonna talk mostly individual because out of your 128 enrolled, 120 are individual. You only have 8 that even take any family members. So just for that purpose, it's easier to understand just the individual. And we can answer any questions about that. And maybe you have more families that wanna come on and we talk about some other strategies we can now do, like insuring a home loan that lowers the cost on the Blue Cross plan for families. We'll get into that too. You have a $1,000 deductible and then an out of pocket of $5,000 for medical and then another $2,000 for prescription. So if I'm an employee here and I have a catastrophic event, I'm gonna have to stay overnight in the hospital, I have to have a surgery. I'm gonna pay that out of pocket of $5,000. And then on top of that, I will continue to pay for prescriptions if I need any, where my stopping point in any calendar year is $7,000. That is the way that your plan is structured now. And under your plan, you have copays. So when you go see a primary care physician, you go to urgent care, you go to a specialist, or you get your prescription filled. And you go down this line, you'll see what type of copay you have for each type of doctor you go see. So for example, you have a $25 copay for a primary care physician, $50 for a specialist, which are generally people with ologists after their name, like a cardiologist, a pulmonologist, a dermatologist, to name a few. And then depending on what you have done, you have copays on your other services. So any calendar year, if I'm on this plan, my max out of pocket is $7,000. And then Blue Cross Blue Shield pays 100% of the bills after that. So, we're showing you, if you stayed with OPH and W, that's that second column where it says renewal. So you drop down and they are, increasing the rates just under 10% when you look at all the tiers. So, it would be going from the 826 to the 903. So we looked at Blue Cross Blue Shield, mapped you to what's close, what can we get to mirror the out of pocket, mirror the copays, and all those things. So the plan that they showed, that option 1 is the Stillwater plan. Option 2 is all others but Stillwater. So if we look at the benefit structure there, the deductibles are a little bit different on this plan. The out of pocket is lower. So on this plan, instead of having a $1,000 deductible, it has $2,100, but your out of pocket is tapped for prescriptions and medical, all bundled together at $5,250 if you're in Blue Preferred, or $5,500 if you're in Blue Choice. So in this instance, if I was that same employee I gave you the example of, I stay overnight in the hospital, I have surgery, and I max out my plan, my stopping point on this plan is the $5,550. So that lowers my out-of-pocket exposure from $7,000 down to the $5,550. And then I get copays on that plan depending on what I have, as far as what type of doctor. So that choice plan is the Stillwater plan, and that rate is $943. We look at the non-Stillwater plan with all others in the state, the benefits are very similar. The stopping point on this plan for the out-of-pocket at the top is $5,250, so that drops the employees from $7,000 to $5,250 they have to spend. And that rate gets you down under what you're paying today and under your renewal. That's at $826. So when we look at how all the tiers divide out, that's a negative 0.2% compared to the 10% you would be taking in July on that plan. I did talk to Melanie, she did a lot of research on, well, how many employees do we have that would have had a claim in the Stillwater plan versus not? And out of your 128, she said around 40 were using the Stillwater plan versus the non. So, we have some groups, and we have more plans to show you about this, but this is just what Blue Cross said in their minds was the closest to your OPH and W plan moving you to that platform. We're gonna show you plans that are richer, and we're gonna show you plans that have different creative ideas that we talked about in our last meeting. But this is the page that, they said this is a good transfer for making the out of pocket a little bit lower and then showing that you can have Stillwater and not, but we also have more. Does anybody have questions about the structure of those plans, and then we'll show you the others that are options.
It's hypothetical. Say one of my guys is looking up on the county line by Perkins and has something that's not working, it's not related like heart attack or.
Huh?
Then they have to go to Stillwater.
Yeah.
How does that work if they're on the course plan?
Yeah.
If they have, that's the clear life saving.
Yes, so a life or limb threatening emergency, you are always coded in network. So if an ambulance, if this person has a heart attack and they're taken to the closest hospital, they are coded in network. It was a life threatening emergency. And that's the same way. And then the other thing is once you cross state lines, you're in network everywhere you go under the Blue Card National Network. So if I get diagnosed with cancer, I have the right to go to MD Anderson, a Mayo Clinic, or a specialist in another state if I want to. So it's really just, Stillwater Med.
Stillwater's our storm.
Yeah, yeah. So, the other thing I'll point out is when we look at the fact that the choice plan is a little bit higher than the advantage plan, but bottom line, they're saving. If you did, you could give employees the choice to do the Stillwater plan or to not. You could even say either it's free no matter which one you choose, we pay 100%, or if you choose the Stillwater plan, we're gonna have you pay the difference. So there's options you can do or how you want to structure.
Thank
Okay, so on the next page, one of the things I had mentioned a bit earlier, and again, we kept in the very first two columns, we kept your OPH and W plan so that as we refer back, you've got your benefits right there. Okay, we can keep a reminder of that. The other thing we're going to talk about today is Insure Oklahoma. That is a program that goes along with your Blue Cross plan. If you have any employees that make under a certain income guideline, there's a chart that the state publishes each year. You're eligible to put them on one of these two plans, and the state picks up a large portion of their cost. So, Insure Oklahoma, if we find out we have any that qualify, we wanted to talk through that. We noticed you have about 14.
There were about 27.
Oh, 20 more than I thought.
Yeah, 28, but that
Sorry.
just shows 14.
Oh, that might be just half.
Actually qualified.
So, yeah, so we looked at your population and who we thought could be a possible candidate based on what we know about their earnings and their family size that could potentially qualify. So 28, and we don't know necessarily if they have a spouse that's working and how much the spouse is making, or the spouse doesn't work at all, so that would increase what they can make. But we can always add this plan on and just call it an Insure Oklahoma plan. And, we don't have to advertise it to employees that we don't know, that we know for sure do not qualify, but have it in case you hire someone. Like if I'm a mother and I work here and I have 3 kiddos, I'm gonna qualify. Or anytime you have an employee say to you, I have a child on senior care, that means they automatically qualify for this. So the benefits are a lot richer because they say, if I'm an employee that makes under an income guideline, I can't afford a $7,000 out of pocket if something happens to me. So they cap the out of pocket to much lower. So that's why we showed these two plans. They say Insure Oklahoma. Both of these plans have a $500 deductible with either the Stillwater plan has $3,750 out of pocket, but the Advantage plan with the non-Stillwater medical has only $1,500 out of pocket. So if I'm a mother with 3 kiddos, I would want to do that plan. Because now I only have the maximum exposure of $1,500 instead of $7,000, and those rates you see at the bottom, the state, like that $961, the state of Oklahoma through Insure Oklahoma, it's sponsored by the TSET fund, the Tobacco Settlement Endowment Trust. It's been around a long, long time. They will pay 60% of that $961 back to the county for you all giving that option to them. So, you actually have a saving for those that end up signing up. And then if I'm the mother and I have the kiddos and I wanna buy that employee plus children plan, that $1,547 is what I have to pay every month, but the state through the TSET fund pays me back 85% of that cost to have that plan. So we wanted to make sure you knew that, because you cannot do that right now with OPH and W. It's not an option. So that's something that is different going direct to Blue Cross. This is what all groups do if they have an employee that can benefit them. So, the 28 employees that we kind of looked at, we will talk after this, obviously, and do a one-on-one meeting with them, explain the great benefits that they have if they want to look at. But that's obviously not for all others, just those that we identify. So then on the next page, we wanted to show you what else can we do, to get. Yes. Well, but also that next column. Okay, yeah. So on the very next page, again, we showed you your current diamond plan, your renewal diamond plan. And then if we look to the far right and we see that advantage plan, again, it's all of theirs but Stillwater, and we look at the rates, you can actually offer to employees a $1,000 deductible with a cap of 3,000 total out of pocket. Dropping that, this is a plan I often do for municipalities that come off of OPHW. It's probably the most common that I place, to be honest with you, because you're dropping that out of pocket from 7,000 to 3,000. You've got good co-pays in the plan, and if you look at the rate, Blue Cross priced you very fairly. It actually gets you right under what you would have had on your renewal with the 7,000 out of pocket. They priced you at 900 instead of the 903.
What you can follow before rates of the function.
Yes, just a little bit. So, but when you look at the bottom line total, we would be taking on that 9.8% increase if you stay with OPHW and then also pay the assessment on top of that. Or, on that far right column, this could be one of the options we show to employees. For the 2,000 out of pocket. And it keeps the co-pays low. So that would be another good option. And then in our last meeting, we wanted to also look at what our other businesses do. How can we do? I know that OPHW in one of their last meetings, they brought in a company to talk about high deductible health plans and catastrophic plans because the rising cost of research fixed us. A lot of private businesses are doing high deductible health plans, and then helping pay towards the health savings account. It's kind of like a flexible spending account, but it's called a health savings account when it's compatible with a high deductible health plan. So that's another great option. And again, you can pair more than one thing together. So we wanted to show you what that would look like. And so on this next page, we have your, so we have again, what you have today. If we wanted to look at doing a high deductible health plan, it says option 1 in that third quadrant. So this is what it would look like to have a high deductible health plan. Right now, your maximum out of pocket in any calendar year is 7,000. So this plan that Blue Cross offers is a 6,150 deductible with a maximum out of pocket if you're in all other networks of 6,850, or it also lumps in Stillwater Medical to 7,650. So the maximum out of pocket is very similar. But you look down at the rates and it drops your 903 for an employee down to 695. So if you wanted to do that plan, now we're looking at the fact we have $200 a month in savings, but the employee premium is, you could take that savings and put it into the health savings account for the employee. And that money continues to grow. It is not like the FSA where it's use it or lose it each calendar year. The HSA stays with you forever. It grows interest inside of the account. It acts as a retirement account as you get older. You can pay your Medicare premiums out of it when you hit 65. So it acts as a retirement vehicle as well as you can spend any medical bills that you have. You can pay for your kids' orthodontia out of it, all sorts of things you can do with the HSA plan.
You go over to another plan.
Yes. So, a lot of the times when a group doesn't have an HSA as one of their products, they'll get an employee that comes to work there and says, well, gee, at my last employer, I had that health savings account and I had, I saved up $5,000 in that account. So they can actually then begin to use it here if you offer. So it stays with you, it rolls with you. If you have a bank, you can also work with your individual bank and they have HSAs too. So you never have an issue rolling it over, bringing it with you. It's kind of like a retirement account method. So, that's an option, and that first one, that has Stillwater Medical, and then the one right next to it is the non-Stillwater Medical. And look at the cost on that one, it's $590. So now we have the difference between $903 to $590, that's again, $310, let's call it a month. That you would be saving in the employee premium that you could put into an HSA account for them. So that's another good option, and that plan has a maximum out of pocket in the calendar year of $6,600, so lower than the 7,000 today. And then, does anybody, that's a lot, so I'm gonna stop there and ask for questions before I go into what the different card does with the.
Can you see our individual employees' expenses?
If you were with Blue Cross Blue Shield, yes, OPH&W won't give it to you.
Okay, well, will Blue Cross Blue Shield give you those before we start?
No, they can't get them from OPH&W.
It's a contract that OPH&W has with Blue Cross and Blue Shield is my understanding, because I've tried to get them from Blue Cross and Blue Shield too. This way, am I right, Caitlin?
You're exactly right.
The contract that OPH&W and Blue Cross has, we'll never be able to get them.
H&W has a board of meeting. This is not specific health information, why can't they, freedom of information act be put up for that?
It's a good question. I don't know the answer to.
So you're looking for like a dollar range?
What I'm looking for is if we can take our employees and know what they use the most. Run it through whatever you wanna run it through, and then we can advise them on what the best plan, pick 4 plans and advise them on what the best plan for them is.
Absolutely.
If somebody that never uses it doesn't need a $100 deductible,
Right.
they can go all the way down, use the HSA, then they can buy cold medicine.
Exactly. When you go direct to Blue Cross, each year, one of the things that we do is we order a report per person. It's called an deductible and out-of-pocket credit run report. So we literally will have everybody's name and what their total medical expense was for that year. And then we have that information and we can help walk them through it.
Send an email to Blue Cross Blue Shield, say, we're not paying you that special assessment, especially if you're not gonna give us information in a timely manner. Maybe money will help. Don't promise you pay it if they do, just say.
Yeah.
Remind them.
Yeah.
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 Okay.
But so to your point, I mean, when we work with a group, they'll say, our younger folks, they never use the plan, they just talk about they want the less out of their pocket and, so it's a fit for different people. Sometimes if you're an older employee, and I always like to give this story, so if I buy that 7,000 out of pocket plan and I know I'm gonna have a surgery, I know I'm gonna spend $7,000. And also, if I buy this 6,600 out of pocket plan, I know I'm gonna spend that. So why wouldn't I wanna do the lower premium plan and have that money put into an account when I know I'm gonna max out my plan anyway? So it's either usually for the young and healthy that don't use their insurance and they think it's great to get money in the account for them. Or I already know I'm gonna max out my plan and I get the money. So there's different reasons why different people would consider a plan.
Well, let's talk about me. I use the VA for mostly. I have a civilian doctor that I use quite a bit. That's just a couple checkups, and if I have the sniffles, I can run get in easier than I can to the VA. And does it make sense for me to have a high deductible plan or a low deductible plan?
So if your checkups are just primary care, like wellness checkups, those are covered at 100% first off.
Right.
Under
So-
all the plans we talked about.
So-
All.
If that's all you're doing with that civilian doctor, then those visits would be 100% covered. You have no out of pocket.
Sure, it's just labs and a checkup, and my civilian doctor likes to check my labs all the time. And
Anything that on any of the plans we've talked about today, the high deductible health plans, the regular plans, anything the doctor says is a preventive visit is covered at 100% no cost. So my well woman checks, when I take my kiddo in for their well checks or immunizations or colonoscopies, mammograms, anything like that is covered, at no cost on anything.
I do have a question about the colonoscopy, so they have had. So they now tell me that it's not considered a normal visit.
Right.
Anytime I have another colonoscopy.
Yeah. And that's
So-
when they send, because when they send it in, they say it's not a preventive exam, it's a diagnostic exam.
Even though the doctor puts on it preventative because it's once every so many years.
Yeah.
Yeah, it's partly because if they put a code,
Yeah.
then, but I have to talk to her, so we have a claims advocate, because sometimes they can submit part of it, is my understanding. And that part can be paid as preventive, and then just the diagnostic part.
What they paid was
So-
everything but anesthesia, they would not pay anesthesia.
Interesting.
And the doctor, it was preventative, but they had previously taken out
Right.
pilots. So
So was the
pay it.
anesthesia because they were out of network?
No, they're not out of network.
That is bizarre.
Yeah.
And
That's
I
where like we
pay
have a claims
anesthesia.
advocate team who would be able to
Well, how
call
long
and
you
they
talked to
could, you know.
There was
put
no
the cost
working
to
with
figure
them.
out. Interesting.
Yeah.
They said they will not cover it because it's not a diagnosis or a
Preventive.
preventive.
Right.
Yeah, because it does have to be covered as preventive.
Yeah. I had the same thing.
Yeah.
I had to start seeing colonoscopy early, so all my family members.
Yeah,
So I have the exact same.
yeah. I was just shocked because I had called them and they were like, oh, it's not, you're not. allowed anything."
Yeah.
And then they send me a bill and I'm like,
You said what? Yeah.
But part of what we do, for open enrollment and stuff is help educate employees. So if you were to offer more than one plan, is we would present the benefits of open enrollment. We would be happy to sit and speak with each person to figure out, like, we can't necessarily say, this is the best one for you, but we can ask certain questions.
Right.
And say, okay, well, based on that,
Mhm.
right, this might be a better option, but just know that. Here's your possible out of pocket if anything
Right.
happened, but I mean, just like Caitlin said, I can argue either way. But you know, having that premium savings or not, if I know I'm gonna max out my plan, I might as well get the premium savings and put that money in savings, but. Some people are not comfortable with not having office visit copays.
Mhm.
And that's fine too.
Right.
That's why, you know, if you do a high deductible health plan, also giving employees the option for that copay, if they're a person that really wants that. And you can switch every year too. So let's say that I was nervous about it this year, so I just wanted to stick with the copay plan, but then now I keep hearing all these people are talking about how much money they have in their account and they're coming out ahead. I can switch to it. You get to switch back and forth every open enrollment too.
In my opinion, since I work for benefits, having an HSA is just another added benefit for each employee. For the ones that don't use it, it would attract more.
HSA?
It's not an
Health
SS,
savings.
yeah. And it don't expire, you gain interest, it rolls over, it's not like the FSA.
What about employees that decline healthcare coverage because they have their spouses doing something for them and have Indian health or whatever it might be? Can they still get an HSA?
No, because the HSA opens up when you have a high deductible health plan assigned to you. That's the medical plan, and so then you can open an HSA.
Okay.
Yeah,
Can
and
the HSA be used for any member of the family or just the employee?
you can also use it for family members as well.
Do they
It's that, there's a whole list of IRS qualifications, and yes.
As long as it's a tax qualified dependent.
But do they have to be covered?
You know, it works very similar to a FSA because a FSA works that way. But this also allows him to retain the money, and roll it over, invest it.
So my wife's not under my insurance, I could see use it for something, right?
And just like the FSA, you know, every year the IRS says, here's your limit you can put in or use. The HSA is the same way. And I think the limit on the HSA is higher than the FSA.
4,000 or 50 and then 8,000.
And you're only gonna hear more and more about these, like the current administration, as they're rolling out their healthcare ideas, they are all pretty much these exact plans, the HSA high deductible health plans. So they are very much gaining in popularity. They've been around forever, but with how expensive that PPO plan is getting, people are trying to do things to, can my dollars go further by doing it a different way? So if you think about it, you're gonna spend $7,000 on a PPO, you're gonna spend 6,600 on an HSA, but then have the savings to put in your account. So
Is, if that employee puts that in their account, is it theirs to pull out for anything? Or just medical?
any IRS qualified expense, so it definitely works for medical, it works for dental, works for vision. There's a store online called hsastore.com, you can go buy, different things, nighttime diapers for your kiddos are on there. I mean, all sorts of things you wouldn't imagine. Their humidifier, I bought one for my son when he was in the crib.
One thing that is different from an HSA than an FSA is the dollars are available as the deductions are taken out of your check. Versus an FSA, those dollars are available upfront, the full amount. The HSA, it's as each pay period, as you have 250, let's say, is how much you're putting in it, as that's entered. That's why sometimes it's helpful if the employer is either matching or, contributing. They'll typically have it to where they contribute once a year or every quarter, so that there are some dollars in there that they have available January 1 or whenever they're.
The other big difference, this probably goes back to your original question, is if you're an employer offering an FSA, you're the one held responsible for compliance with the IRS. With the HSA, you're just doing the deductions and making the deposits, that each individual is subject to making sure that they. I don't know of an instance where someone's pulled money out where they probably shouldn't have for something, but it probably exists somewhere out there. But by and large, if they're using their card, everyone uses an inventory separation software on their machines, they have to be coded a certain type of thing to be able to use the card, so it's made it a lot more difficult to be able to pull money out for bad things. Now, with that said, it's qualified money, so if you were to do a withdrawal on it, it could be very much subject to just like an early withdrawal from an IRA, where you got a 10% excise tax at prior to 59.5 plus income taxes on it. So there is ways to get it. It's just, in some ways, it's like an IRA in that regard, where when you pull it out and it's not for a valid expense, there's going to be a taxable event for you and a penalty as well.
But on an HSA, they have, like you said, when you submit the reimbursement request, you don't have to submit the receipt or the EOB like you do for an FSA.
It's actually
Match
much
up.
easier.
It's a lot easier. But if you happen to take, if they are questioning it, then they would, there's a potential of an audit, make sure that you did use it. But as long as you have something that matches up.
If you go to the local pharmacy and you are paying for your prescription, you can also throw a candy bar in there. The card won't work for the candy bar. It'll only work for your prescription because it's coded for qualified.
Sound like you tried that a time or two.
Can you get vitamins?
So it depends what kind of vitamins. Yes. Over the counter vitamins, if your doctor writes a prescription for over the counter vitamins, yes. So, cause like talk about maybe a vitamin E or something, you can either your doctor writes you a prescription for it and you can go buy the over the counter one and that's completely qualified. But over the counter drugs is hit or miss the IRS list. During COVID, they made it easy. They said all over the counter covered, we don't want to deal with it. So you could just go buy your Tylenol or your Sequel or whatever you wanted and it was all qualified. Now they've kind of done a mix of some are, some aren't. But when we look at that plan, that option 2, and we look at the bottom line savings, and it's 28% under. No. Right. So So if you look at it that way, to Tony's point. Really. 38% of what you're getting is an OPH and W. And yeah, if you look at the bottom line total, 389,000 under current. And then you add 132,000 of your increase and you add that to the savings, so then we're looking at 500,000 of savings. That's a lot of, it's a large bucket of money that it gets creative with. Our company has pretty much priced out the PPO. It's super expensive to buy the PPO. They encourage you to go to the high deductible health plan. It's much more affordable for us, so. I mean, I don't think we wanna do that this year, because we're making a change, but every year when we sit with you all in your strategy meetings, we're gonna show you, here's what your employees look like, here's where they were using the plan. What should we be thinking about or talking about as an option? So now that you're gonna have control over your program if you do this, I think you're gonna love it. Giving employees choice and getting creative with dollars and helping with the high cost of that care too. The premiums are only going up.
First year. We need to give the employees like 3 options. And then whatever the state funded one would be.
Mhm.
And let them kind of navigate that, give them you have this much money to navigate through here, and this is what each one would do. And then the next year we'll understand this plan better, understand what our employees need, and then we can offer a little bit more detail.
So you're saying don't offer the HSA the first year?
No, I think HSA would be, there would be more options, a high deductible plan with HSA. Whatever, next step up, and then the Stillwater plan.
Yeah.
And let them choose, and then the next year we can get a little more creative.
Does that
That's,
work?
that's just mine.
Yeah.
Does that make sense, or
It
would
does.
you argue?
Yeah,
Yeah, because even being fully insured, you'll now get a level of data on a fully insured plan that you've been restricted from getting from OPH and W. You will understand where members are using the plans, how many members, maybe on the aggregate reports, you're not going to see the names, we can get that for you, but you're gonna be able to know how many people spent under 500, how many people spent between 500 and 2,500, how many people are over 5,000. That gives you a really good barometer then to look at, how many people are likely to go into HSA. We use that as part of the communication to go, did you know only 8 people went over $5,000 of expenses last year? So if you got money going in, you can lower that out-of-pocket exposure. So you're putting $2,000 a year in, now that plan is at 4,600 out-of-pocket compared to 7,000, starts to look a whole lot better. And they understand it, that kind of resonates with the employees.
I'd like to get to a point where we can help subsidize families. For families, even on your lowest plan, there's
so expensive.
hurts.
Yeah.
Touch on that, 1/3.
So we have another thing we haven't talked about yet, I'm telling you, Melanie. Yeah, you said you wanna see the creative thing, so we're showing it. So now,
Your
that
request
same
rate
page
for creative.
that we're on, if you go to the very far right, it's called different part up at the top. It's the exact same Blue Cross Blue Shield plan that option 2 is that we just talked about. So that one we just spent time talking about, that has a 6,600 deductible with 6,600 out of pocket. That exact same plan, but we put the difference card on it. So what the difference card is it sits under the deductible, and because of the savings, comparing what you're paying at 903 per employee, it drops it to that 590 that we talked about in that 6,600. Now we give every single employee that gets on that plan the first $4,000 of medical bills, all medical bills paid for them. So then they only have 2,600 out of pocket that they have to spend in medical expenses. It's small.
And that's How much a month?
So that one comes out to $881 a month to do that, from the 903 that you'd be renewing at.
And that takes their out-of-pocket exposure from 7,000 down to 2,600 a year. So price-wise, you're looking at, okay, it's still an increase from where you're at, but you're also basically giving them back $5,000 of out-of-pocket expenses they would have had to hit in that given year. So it's probably one of the richest plans on the page,
It is,
in the presentation.
The out-of-pocket is 2,600 if I'm an employee.
And when you're, we talked about how people are using the plan, how many people are hitting a certain threshold. I would venture to say over half of your employees would not have any medical expenses out of pocket if they had the first $4,000 paid for them. And the ones that have chronic conditions are gonna be capped at 2,600. So, so it's been a really popular approach for groups that are looking in the fully insured market. That can be offered as an option. We keep them always options out there.
Yeah,
But it certainly can be. It's kind of like a baby step towards an HSA. That's a guaranteed underwritten HRA program. So if we get to the end of the year and there's an overage left in that account that your employees didn't spend, that money comes back to you.
Does it go back to the county or back to the employee?
The county, because it's never the employee's money, it's always the county's money under an HRA. It's only becomes the employee's money when they spend their eligible amount. The other concern that I would have is if I had somebody who has chronic conditions, they're on high dollar medication and they blow through their $4,000. Now they're gonna go to the pharmacy and their prescription is $2,500 to get. Chances of them paying that $2,500 are slim to none for most people.
They would walk away.
And they end up in the hospital and you're paying $10,000 for that script. Difference Card underwrites this, and once that $4,000 on that individual is gone, they still pay 80% of the cost of their drugs over and above the 4,000. So that person reaches their out-of-pocket max.
So if I'm a diabetic, we know if you're on your Blue Cross plan, diabetes medications are about 1,100, or let's call it 1,000. Some are 900, some are 1,200. So if I walk into the pharmacy and I've spent my $4,000, and I've only got 2,500 left to spend before it's a free benefit for the year, but my prescription's $1,000, they're gonna say you owe 200, we pay 800. Which a lot of those high cost medications on your current plan, if you look at, you've got different copays, so they're used to paying a higher copay when it's a high cost drug.
And then you just have the deductible first.
And they have a $2,000 deductible.
So-
Yeah,
That's one of the reasons we really like the difference card is because it really rewards those employees who aren't like heavy users of medical plan by giving them free healthcare, but it also is taking care of the chronically ill with their prescriptions so that we don't end up having people get off meds in the hospital.
Yeah.
That just increases things. So
but when you put on the difference card on the high deductible health plan, you can't have an HSA account because they're paying first dollar coverage for you, so that throws it out. So again, as an option, the employee could say, I want that one, but then you also might have an employee say, I want a true HSA because I want that money to grow in my own personal account.
well, and that one would be a great option if you, want the high deductible health plan, but you can't contribute to an HSA because you have access to Indian Health or you're on TRICARE or something like that, or Medicare eligible, you cannot contribute to an HSA, so you could still have 4,000 in free care, right? And that first 4,000 and still have the savings, so that's a positive there that you could still have an ADHD plan, but have your out-of-pocket covered mostly.
They say TRICARE doesn't qualify for HSA.
Correct.
What
Because
about,
you have first dollar
what
coverage.
about VA disability?
It doesn't either. Yeah, that's the IRS regulation now.
Cause they always get second. So.
Yeah.
Yeah, because, so like my husband's a disabled veteran, and so I have Champion. I have a high deductible health plan at work. I cannot contribute to an HSA for myself or him because I have first dollar, because I have no out of pocket under Champion, so, yeah. Yeah. I could chance it and see if I get audited.
You do the one out.
I know, I've asked all the questions of our compliance attorney.
Every other, is there a loophole?
Corey, what can I do?
Yeah.
He's like, no, Kim, we can't do it. I'm like, yeah.
So the whole concept of difference card is really just, you know, if we look at your building as in, trying to use this as an analogy, you know, you're gonna have 25 light bulbs burn out for the year you gotta replace. You just budget it instead of paying for insurance on it. That's kind of the whole concept of the HRA is you know, you're gonna have a capped amount. Just budget for it, build it in, and then instead of paying the insurance carrier a premium to insure that, you're just paying the actual cost when it occurs. So a lot of groups are looking to spend less on the actual insurance premium, and they're just self-funding that balance. And that's allowing them to keep their budgets flat, or in most cases, significantly decreased. So,
And that different part is standalone, or do you have to have something with it?
we partner it with Blue Cross on
Yeah.
those plans, so it's partnered with that particular plan.
So when I go to the doctor and I'm an employee, and I say, here's my Blue Cross medical card, just like I always do. And they're gonna say, you don't have a copay because you're on a high deductible health plan, but we'll, file it with your insurance. So then I get a bill in the mail from Blue Cross on what I owe, and I just use my difference card, just like I do now, to pay the medical bill.
You get a Visa card, but if you're asking, you have to buy something else in order to get difference card. Now, difference card is a standalone vendor that bolts onto Blue Cross, United, Aetna, any of those plans.
Still pretty expensive for a family though, it's 2,000 something.
Yes.
But that's interesting, I like it.
Yeah, I mean, the whole thing is, do I wanna pay Blue Cross Blue Shield $900 for every single employee that works here? Knowing that only by rule of thumb, 20% even get into their deduction out of pocket in a year. But I'm paying like every single one of them are, so,
But this one we pay into it, if they don't use it, we get them in the back.
yes. So on this one, you're kind of pretending like every single employee in this whole place is gonna spend $4,000 in medical care. That's not going to happen.
Is does this one work at Stillwater?
This one, we can show you one that works with Stillwater. This one is, I just priced non-Stillwater, but this exact same plan is available with Stillwater. It'll just be higher in premium.
Yeah.
So yes, it can, but this particular one, just for this analysis is Advantage Center.
And she talked about the Insure Oklahoma qualified plans, and you talked about the subsidy for the employee. But there is a subsidy for family members, they pay 85%. It's an Insure Oklahoma qualified plan, so those two plans that we showed that had either the $500 deductible or the $1,500 or $1,000 deductible, $3,000 out of pocket. On those, there is where they're subsidizing, so in the folder, there's the 2025 income guidelines. And they update it every April, as what the income guidelines are, so if anyone qualifies, instead of them, and then there's an example of how many would potentially qualify. And it gives you on that sheet.
Like this.
Yeah. And it gives you on that sheet how much they pay now with your current plan. And how much they would pay with family coverage if they qualify.
So if I'm a mother and I work here and I have 2 kiddos, I can make $60,000 and then get 85% back to insure my kiddos of the cost. Because I'm a family size of 3 in that example. Or if I'm a gentleman that works here and I have a wife that maybe just works part-time and we've got 3 kids, I can make $85,000 and qualify.
And then the stapled items show you like the premium cost. So like instead of them paying. $1,700 a month. Without the insurable subsidy, they would pay $374.94. And the county would only need to pay $225.03. So you could technically subsidize a little bit more of that if you want. Because the state asks that you just pay 25% of the employee only to. They subsidize the rest. So. they ask that the employee pays 15%. So a lot of groups, what they'll do is they'll adjust that amount to where maybe the employee's paying 5% instead of 15%. So that everybody's amount is the same, because sometimes someone might qualify for a higher subsidy from the state than the 60 or 85%. So you don't have to change your payroll deductions based on that, so. You mentioned offering, I think, one of them that had the state subsidy, so it's thought I would just share that.
Yeah, we did all the, yeah, we did all that work.
Yeah.
So it's good so that you can see if I'm an employee that works here and I happen to qualify, this is what I'm gonna see, 300 to for my family instead of 1,700.
And they get the plan that either has a $1,500 out of pocket or a $3,000 out of pocket, depending on which insurance home qualified plan you offer.
Well, this insurance, Oklahoma, there's a minimum income.
Yeah, it's this chart,
Right.
yeah.
That's interesting.
Mhm.
So if they make below, they're a family of five and they make below $4,300 a month.
And they would probably qualify for adult and kids senior care if they make less than that.
Yeah, so Oklahoma, a few years ago, if you remember, there was a lot of talk about raising the Medicare levels,
Medicaid.
Medicaid levels across all the different states, and Oklahoma was a little bit later to adopt, and they didn't raise it as much as some other states did. But that's what that minimum applies for, so if they're below that minimum, then they're actually qualifying for Medicaids.
It's called Center Care 2.0,
Yeah.
is what they call that.
So,
For the adult.
And a family of four. The employee, the spouse, and two kids.
Yes, yes.
or it can be just an employee and 3 kids.
Mhm.
I mean, so
Yeah,
yeah.
right.
Yep. And that is the household income, so. If you have like a teenager who lives with you and they work, that would potentially count as household. I've had that happen for some people, they're like, wait, what? I'm like. So. But it's an awesome benefit, they also have where they can get reimbursed for some of their out of pocket also, so co-pays, deductibles and stuff, they just have to submit claims to the state.
So we did enter Oklahoma before, it was right when I first came, and we didn't do it because it's a lot of paperwork. So is that gonna be a lot of paperwork for me again, if we do one of the enter Oklahomas?
So was it, it can be, so was it? Did you go online and send us stuff, or you had them fill out a form?
No, back 10 years ago, I still worked in Oklahoma, so it was before they had a portal.
Yes, there was no.
Okay, yeah, so they have a portal.
Back then, we had to print the paper packets and fax it. That was the way that email. You
Yes.
have to fax it and then you have to call 1-800 number and go through these different tier departments to see if they got it.
Yes.
But now
It was
it's
a nightmare.
It's an online portal now.
Okay.
Now it's you basically is you set up the employer site, you go on there and anyone you think might qualify, you enter their name and their social. And then about a day or two later, they'll assign them a number. So you give that number, they even have like a template letter for them that you can say, here's your number, here's our employer number, so it links them to you. They can go online and register, for, if they don't already have a senior care account or whatever. They can go online and register, or even faster is to call, and they
have
talk to
live
a person
does it.
who can say whether they're approved or not, because they have access to the system to see. But yeah, and then once a month, you just go upload, the bill, the full Blue Cross bill every month, and then they ACH, the subsidy. It's a lot easier than, yeah.
Yeah, it was horrible.
I know.
When I came,
Yeah.
I'm glad we did it very long.
Now it's a portal, so it's, yeah.
And what I like about it too is, let's say that you have an employee that works here, getting married, and they don't qualify, but if that spouse loses their job and is having a hard time finding work, it's linked to the Department of Labor, so the wages, so they can just call in and get on, and it's a qualifying event.
Oh.
But I mean, it's just nice to have it built. I mean, you may only have a couple or maybe nobody, but might hire someone that can get on, so just getting it set up.
Well, it sounds like easy.
Yeah, we'll help you with that.
Okay.
Yes.
What about retirees?
We haven't got that yet, have we?
So retirees, those who are under 65 can stay on the plan, and we rated those in this. Those who are over 65, my understanding is they are on a Medicare supplement through Blue Cross, and that subsidy every month is applied, the 105 subsidy through overs. But I know there was someone who, he's retired recently, or about to, his wife is under 65. You have to set up your plan document and eligibility to indicate that it's employees and then spouses of retirees who are under 65. So spouses under 65 of retirees is the way you'd have to word it, for them to be able to be covered. Cause I think that's what they recently were told by OPHW. It wouldn't cover her under the medical plan. Because he's not active.
True.
Will you say that again? The spouse wasn't covered because the employee,
The employee was over 65, so he had to do like a plan, because they put him on Medicare A and B, if I remember correctly. But his spouse is under 65, and so OPHW would not let her stay on the health plan. So she had to get off.
On this plan, in that exact same example, the spouse could stay on this plan because she's under 65, even though the 65-year-old employee went to Medicare.
You just have to have it written into your plan document, specifically that spouses of retirees that are under age 65 can be on the plan.
does her part go up when he goes off?
Well, right now she can't get it, but if we change.
That would be up to you as far as, cause she would then be the employee only tier. So if you're not currently contributing to spouses, then her rate would be whatever that is. I don't know how they're doing it or how they were doing it. Under OPHW, because my understanding was,
Well, it's all changed since January,
yeah.
I don't have everything for you anymore.
yeah,
It used to
so
be.
the documents that we found, it
Yeah.
looks like those who are over 65 go to the Medicare supplement. And I think one of the documents that you had from last year, I think, showed a rate. Maybe for those who are under 65, like spouses or something.
It used to
Or
be,
retirees under
originally,
65.
yeah, they originally introduced this was a couple of years ago. And if you retire, then for you and your spouse was supposed to have the same coverage we did, and it cost with the $105 back from Overs was like $227. That was for employee and spouse. Well, then that changed. And then it's changed again, and then it changed again this January, and I have no understanding of it because I thought I understood it, but then when I sent my retiree couple up there and they came back and told me not what I knew, so I have no idea at this point.
We do have a couple of groups, that have retirees and they are on a Medicare supplement, and we submit every month for them the over subsidy for those two. And it's an individual's Blue Cross Medicare supplement. And I'm trying to think, like, I can't call Blue Cross unless that retiree's on the phone with me to help them, because I've had to do that before, because their premium goes up every year.
Yeah.
But my understanding is it has to be, to get the over subsidy, it has to be a Medicare supplement plan through Blue Cross or something. Yeah. And I think probably what they were doing in the past was rating, because some groups will say that you could be on the plan, but if you're, and Blue Cross can rate it if you want to have even retirees over 65 under the plan, but you'd have to have a rate where they have to be enrolled in Medicare A and B, and their rate can be adjusted for those who are Medicare, and then the spouse who's under 65, so it would be a different rate tier. Just to be able to get this quickly, I was like, let's just wait, because you didn't have access to those retirees who are over 65 easily. So that's why we didn't quote it. It would take a little bit of time to get their
The
information.
ones he gave me, it was all Medicare. They were only on dental and vision. I have no idea who's on medical, but I can't get that.
Right, yeah, right. So yeah, we can quote based on what you know now, right? Or if we can get their data, we can get a quote to where it's showing that. It's just including those who are over 65 retirees raises your rates because the risk is higher.
So when I did this audit, we have 5 retirees that's under the age of 65. That's taken all benefits, health, dental, and vision. We have 41, I believe, that's over the age of 65, and they're only taking dental and vision because they have forced them to the Medicare part, or Medicaid part. So, but we've asked to lower the rate, the age to 62 instead of 65. For the new retirees.
Do we pay a percentage for the retirees? Or do they pay the same rate?
No, they get a discounted rate, is my understanding. Again, it changed in January, but they get a discounted rate, but the county doesn't pay any of theirs.
What is the rate for retirees?
Through OPERS?
No, it's on your, any of these.
We don't, this is not including, it's only the ones who were under 65
Yeah.
on this. Because we were able to get that information.
Okay, oh, yeah.
Yeah, because once they turn 65, they go on to Medicare.
Okay,
Yeah, but, I think I have the OPERS, or no, sorry, not that, OPH and W right here. Right. I'm sure. Oh, yeah, there you go. So yeah, they have like a Blue Cross Blue Shield, Medicare Advantage, open access PPO plans. This was from 24 to 25, so I don't know what it's changed. That monthly premium was $149.80. And so my guess is they may not have that now, so they have the choice between that or there's a Blue Cross Individual Medicare Supplement Plan, which again is a standalone with them. That they have that overs $105 that's to be sent to, but it looks like again, the Medicare is different, otherwise they're paying a higher premium is what I can tell.
So I know with OPH and W, OPERS sends the 105 directly to them. And then they bill the retiree the difference. Is that still gonna be the case if we were to switch?
So what we would do is work with you and OPERS to get it set up to where you have an account with OPERS. A login and you submit those and it goes instead of to OPH and W, it would go to Blue Cross directly. And then yes, the members are paying the difference to Blue Cross. Cause that's how it is. We have Grady County Jail. And so we work with them on, they have a couple of retirees who we submit that subsidy request every month, and they have to increase their checking account information every time, because I had one, he didn't, and he's like, why am I behind? And I was like, I don't know, let's call Blue Cross together. So, yeah, it looks like they have like and that's what I think the city of Oklahoma City has, they have a special, they're self-funded, but they have where they have a Medicare plan, but they have where theirs was set up when I worked there many years ago, was like, if your spouse was under 65, they were on the plan, so the rate was based on if you were 65 or not. So, yeah.
So basically, we would still have retiree coverage.
Mm-hmm. Yeah.
What about dental, vision and life?
So, we only brought medical and dental today. We'll have everything else ready to review with you. I know this was, we want to cause as little disruption as possible, and the medical is the biggest. But the other nice thing, I think you all have Delta Dental right now.
No, we have Blue Cross and Blue
Oh, you
Shield.
do have Blue Cross. Okay, it's the health course plan that has that. So we also showed you Delta Dental, Blue Cross Blue Shield
Yeah.
Dental, and it is lower, so that's on the next page. And the great thing about it is all these plans we just talked about on medical, Blue Cross Blue Shield, if you buy their dental product, it gives you a percentage off the medical. So every rate you saw on all those medical tiers go down, which that's a lot of money when you look at the annualized total of thousands of dollars.
So you'll see they they quoted, the dental plans there, the first one, option one, has a $2,000 benefit maximum. And it also has an orthodontia maximum instead of 1,500, you have currently, it's 2,000. It's still a lot cheaper than what you have currently. But the one on the far right is actually the best as far as it does $5,000 benefit. And it has a $25 deductible for individual with 75 disability. The difference in these, you have the 60% on major and it's 50% on this Blue Cross plan option 2. But the premium, you're currently paying $49.76 for employee only. That option 1 would be $33.49, or option 2 is $38.64. So there's some savings there. For members.
And I believe ours was going up to 55 something with the enrollment
Do you
period.
guys pay anything towards dental or?
Yeah, we pay 100% of dental.
That's what
vision.
I thought. Okay, that's what I thought, and that's how they quoted it. I just was like,
Yeah.
let me make sure, because that makes a difference, but. No, so Blue Cross, they were able, like, so part of when they send us a quote for medical, they automatically included dental, in it, so that's why we're. So the vision and life are stuff they have to add it right.
Okay. So this option 2 here is actually better than what we have.
It has a $5,000 bucket of money spent.
And it's cheaper.
Yes.
Yes. Cheaper on all tiers.
Fine.
Get some savings, nothing.
I'm gonna tell you, Marlon's favorite subject is insurance.
Oh,
Yeah.
no.
Direct your questions to him. So, and I have a question too.
Yes.
And I know this because Marlon's wife works at the dentist office here, and they don't take our Blue Cross Blue Shield, isn't that correct, Marlon? Or,
There's something, but
There's some way, because that's where I go.
oh, so they do take it?
They just bill, yeah. I think they just bill them directly instead of it.
Okay. Well, there was an issue with that at one time, and people couldn't go there, that was only going to that, and I wanna make sure it was gonna be covered, because it's here in town, it's convenient for everybody, so. Yeah. What did you sugar?
That's one that I
Well,
think
good
is
shape, yeah.
So yeah, they are Blue Cross, so Blue Cross, we also are, we reached out to like Delta and some of the others just to see. It just takes a little bit of time. We might have different options and we can check and see who's in that work, like people do there. Okay. And then Blue Cross did provide, because normally when we have a group that we can have access to information, we would ask for a network disruption analysis, meaning based on your actual claims, the doctors that were used in the last 12 months, how many would be in network on each network, right? So that choice, preferred, advantage, and then you would truly know how many people are not getting access to the providers they want based on what network you choose. We can't get that. So what they did provide that we can read with you is, they call it a 360 analysis, and it will show the percentage of providers that are in network. And they showed against preferred because they just assumed that you guys use preferred. But it's like, do you not have one for choice? So I asked them for choice. Yes, you do. Yeah, so,
That's one.
it's just that because, yes.
Yeah, I'll give you that.
Okay.
So, she's working on getting me the choice one, they just already had one automatic for preferred, so. But generally, they're all in network except for Stillwater.
Dang, those Stillwater.
I know, we have groups that are just like,
I just don't know,
I
they don't
just
want
can't
to
afford
play.
it. And the thing is, you pay a higher cost in claims also, because their contracted rate is higher under. So.
so if we chose a plan that didn't include Stillwater, but employees wanted to pay additional, they can add that.
Yes.
Yeah.
I can.
So that very first page we talked about, I mean, this is a great example from how much more expensive it is, because the benefits are identical. If I want Stillwater Medical, the employee only rate is $943. If I get every other provider in Oklahoma, it's $826.
Like what, $120 savings?
Yeah, and then times that by 12,
Yeah.
just to have, maybe I go for a visit or two, I gotta figure that out.
And you know, we could educate on like, if you're just going to see one doctor out of network, then you could probably pay a lot less. You pay $100 for a visit versus $1,200 a year in premium, right? We have a Blue Cross Network, or it's national, but I have a provider I like to see once or twice a year, and I just pay her $100 every time because she's not in network.
So is it $100 and they don't use your insurance?
It's yeah, she just charges me $100 cash. And
Yeah. Yeah, my son plays soccer and every once in a while he has to go to the chiropractor and the chiropractor says, don't give me your insurance card, I'll do the visit for X. Just avoid insurance because they're gonna charge you more for that, out of network, yeah.
Well, the 120 times 12 is a $1,440 savings a year.
And truly, like you said, if it's an actual emergency and you need to go to Stillwater Medical Center, it's an emergency, it's rated as in network, it's the same cost. Right, you're gonna pay it in network, co-pay, co-insurance versus.
If you had the thing, and you had the money on the card and you went to the chiropractor team.
You can pay for it.
Oh.
Answer, that's a good question, yeah.
Just out of curiosity, the thing that your doctor charges you $100 for, what does he charge the insurance? Do you know that?
When they were in network, it was like $180. And then it would be negotiated down to like 100 and something, but she's getting about the same, just not having to file the insurance.
That's probably worth something, because then you have to wait, what, 90 days to get paid and all that.
You spend more in envelope.
Yeah.
Yes,
Yeah.
and time, yes.
Yeah.
Now, vision, we have, BSP enhanced,
We can
so,
do it,
Yeah.
because I think BSP's taken everywhere.
And then the
Pretty much.
life insurance and the voluntary life,
Yes.
we grandfather everybody, whatever policy they have now, the new carrier that takes over, everything will be grandfathered over.
So say I have $350,000, I get to keep that, and it's not guaranteed issued 100,000.
Yes, so will we do a true guaranteed open enrollment, and anybody who's already gone through that process to get above the guaranteed issue is automatically approved, that amount is applied for them on the new policy.
Oh, that's good.
Same premiums.
We haven't quoted it yet, but it'll be super similar, yeah.
Just cheaper.
Yeah. Yeah, it might be, maybe. I mean, Grady County Jail was a little bit cheaper.
And did they go with MetLife, Grady County Jail?
Well, when we first took them over, they did Dearborn.
I've heard of them too.
Because back in that day, 2018, when we did all this, they were owned by Blue Cross. But they considered Blue Cross to Blue Cross.
And then you have the life insurance that has employee, spouse and child that
Uh-huh.
they pay,
Mhm.
right?
Yeah.
And then do you have the retiree life also? Or no?
No, we don't pay that.
Okay.
No, because retiree life is not good.
Yeah, it
It's not.
decreases in
It's
that.
like,
Yeah.
and you have to pay
So
more
the
for it,
premium is a
and you
lot.
get less, yes.
You get less insurance. for higher
Yes,
costs.
it's not very good at all.
Yeah.
All the policies are like that.
Yeah. Are they?
Not just that, I mean, they're all like that, yeah. So the one thing we haven't talked about, I told you we were gonna go back to that page, I'm sorry, one more thing about your run out claims with OPEH and W. So because you're with OPEH and W, and what we've heard is they're going to keep you on the hook for paying your run out claims, so I'll give you an example. Let's say that's July 1st, you say, we're going direct to Blue Cross. If you had an employee, let's say in June, that went to the hospital. Well, that takes a while to get through the whole insurance change, because the facility has to file it, goes through the process, what's negotiation, and then the bill comes. So OPHW is gonna cut off paying any bills July 1, your day of the week. So, because you're the employer of record and that employee used the insurance in June on the self-funded plan that you guys are on through OPHW, we wanted to show there could be costs that come that you would still be subject to. So on that very first page, that's what that's going to show. So, that's only gonna be this one time. So then you're gonna take over your plan and that will never happen. We wanted to show you kind of a low estimate and a high estimate. So, employees are filling prescriptions in June and they haven't hit the bill yet and for a doctor's visit. So we just estimated based on what your monthly claims were each month on an annualized basis. We just estimated what it could look like. You had some months that were lower than this, a couple months that were higher, so we just showed what that would look like.
It looks, they should be on the hook for it if it happened within their yearly plan. But
And they said they won't pay any claim that comes in after July 1, is what we've heard.
And then there's supposed to be our roll off is 6 months. And then, our rolling claims 6 months, isn't that what? I understand.
I don't recall exactly, but
It's not in the contract.
that's serious.
6 month period. Well, I mean, OPHW was, I think, sold and marketed to everyone as like a fully insured plan. It's really self-funded. So when a member exits, there's always claims called incurred but not yet reported that are out there that have not been paid. That's the part that we're showing here. So conservative estimate on maybe a little on the low side, 8%. Not uncommon that we see Blue Cross claims go through at an 8 to 9% rate. 12% would be more of a high estimate. So that's gonna be a one-time cost over that 6 month period of claims that when they can come in and get finalized. And you'll see the majority of those in month 1.
Yeah.
A lot less in 2. By the time you get to the 3rd month, it's trickled. 4th month, there's nothing. Somewhere between 150 and 225,000 is what we estimate.
So if, say years down the road, we're in this situation, and we're not happy with you guys, what is your,
You're on a fully insured plan, so you wouldn't have that happen.
To her point, if
They would
it
be
was
paying.
incurred while we were with you, you're on the hook for it, she's fully
Yeah.
insured, she's 80%.
It doesn't matter if it took the doctor 12 months to file the claim up. It's not an additional cost. So there's the negative.
there's what?
I said
The
there's
negative.
Negative
Yeah.
about that. And let's go back to this at the end.
There had to be one negative, huh?
Yeah.
It's anytime you exit a self-funded program, you have that run out and mobility. Even groups that have their own plan and say, hey, we're gonna go back to fully insured, they still have to account for that run.
So I'm still learning a lot. So you're a fully insured plan.
This plan that we're talking about today is.
And that means that the carrier is gonna quote you a price and they hold all the risk. But if you outperform, they also keep the reward if you don't lose all those dollars. When they're self-funded, you have the ability to, we help set rates. If you outperform, you keep the difference.
Kind of like on that difference card we talked about.
But it also, if your population incurs a lot more claims, you're on the hook for that risk. Up to a certain level, so. But the fully insured, like Caitlin just mentioned, if it's incurred during the policy period, it doesn't matter when that claim comes in, the fully insured carrier has to pay it when it does come.
And so the reason why we just showed you fully insured is because you have no access to your claims data. So to move you to a self-funded program without even understanding what your employees are using it for, do we have claims and medical diagnoses, and we just don't know. So that would be a very risky thing to do year 1. But as we go through this year and year 2, we are going to know all about your employees. We have all the claims data. You get a Blue Insight report. We do claims dashboards for you. So it may be that, in 1 to 2 years, we're telling you, you're a great fit to go self-funded. You can outperform that fully insured contract.
So when we were out last, we talked about doing the gradient AI scoring.
Yeah.
And so in your folder on the right-hand side, this is what it looks like. And I'll kind of quickly go over this. We didn't put the whole report because it's got pages and pages and pages of diagnosis and stuff. So we took that member level census that you provided for us. And the very first thing, match rate, 86.9% of submitted members had at least one claim in the aggregator data sets within the last 6 years. So, I would personally like to see that a little bit higher. I'd like to see it in the 90s, but that's just how this one matched up. So right below that, you've got a demographic risk score. A demographic risk score, let's just say normal is 1.0. The two things that make up the demographic risk score are age and gender. So, if, for example, females under 42, 44 years old are more expensive than males in that age. They then flip, older men become more expensive, females become less expensive from an actuarial standpoint when it comes to insuring. So right now you're about 26, 1.26, 26% above what would be considered normal or par. The morbidity risk score is based upon all the information that was pulled on diagnosis codes. That shows a 1.61. To Caitlin's point, we don't really know, okay, there's always the chance that somebody prescribed a medication for off-label utilization for something else, but maybe it's flagging for a leukemia, maybe it's flagging for something. You don't really know without having the insight to look at your claims. So a lot of times we use this just to get an idea. And then the overall score is a 2.02. So for most of our stop loss carriers, this one, when they run this, because of no claims data, it's going to be an automatic decline when it's that high. So it's basically 102% above par. The back page just breaks down the members and number of members and into a risk field. 0 being low risk and 10 plus being high risk, and tells you how many members you have. So I just go to the 0.75 to 1.0. You got 11, 5, I'm going down to page 13. You got 12 that are between 2 and 3. You got 18 between 3 and 5. 8 that are 5 to 10, and 10 that are 4 that are over 10 in terms of that risk score that when they ran the diagnosis. So that's something we'd be really hard pressed to come out and give you a 1-year quote and go, let's go self-funded. And we kind of know this, so it's probably not the prudent choice to make. It's not the right step at this time. But by getting you on a platform where we can see funds, we do understand what's going on with large claimants. We're not just having to rely upon the pharmaceutical files and the medical information you're going to. So.
Where do we sit on like an average? More healthy, less healthy in the middle?
I mean, on that risk score, it says you're less healthy than
Okay.
But again, that's, we don't have any line of sight in that to know is all of that valid, is all of that. I mean, I have one group that we ran that on and they came back and said they had 2 hemophiliacs on. We've never had a hemophiliac on it, but something triggered in the prescription files that a drug that a hemophiliac would have been given was administered to someone on that plan for something. So to this day, we've still never had a hemophiliac show up. So we don't 100% trust that without having the data to go along with it. Now, it's kind of going back to Caitlin's point about let's take the right step, and that would be to move to fully insured, where we do start gathering the data, we can start giving you reporting, we can talk and go over the large claimants on what's going on. And then we're in a much better position to know, is this really accurate, or was there something in there that got mixed up? Because we don't get any identifiers back on any of that, even on the full report. There's not a single name on it. It just lists all the different conditions that a member has been treated for the last 6 years.
So last year when OPH&W gave it, whatever it's called, not an assessment, but a fee for losing money, and we paid a fee, basically they're telling the truth. We're unhealthy, according to y'all's numbers.
Yeah.
Okay.
I mean, the challenge is OPH&W isn't breaking each group out and giving like true reporting to go, here's. So you're kind of like in a ship. You're in a ship with no steering wheel, no rudder, and you're just having to float along and go along however the current takes you. And you're not able to step in and make any changes or even understand what's going on. So
I mean, some groups we talked to said they're extremely healthy. They didn't have any claimants or anybody off board, and they had an assessment. So,
And I don't know this past year of anybody in any of y'all, I know there's nobody really at the courthouse, but any of y'all's farms that had like a major heart attack or stroke or something major. I just don't, I cannot recall anybody. But our numbers were really high, the ones they sent us, but my understanding from OPH&W is they have 97 people on their plan, municipalities or counties. We're all under the same group number. Everybody has the same group number. Lincoln County's don't have their own individual. And so they're just pulling claims,
Wow.
is my understanding,
And
And
manually keying.
and manually keying them. So we had, the information they have sent me, we have no way of knowing if in fact it's incorrect.
From with people from the county or.
Yeah, not, we don't know,
Yeah.
and I can't get that.
So are you guys gonna be able to keep record of us on
Yeah.
our own, and if we're a healthy showing signs of improvement, all those things, then we get a cheaper rate?
Yeah.
We'll have access to watch it every month too, because they send report there, or we have access to get on Blue Cross and Blue Shield, and we can watch it each month and see where we're going.
So you're gonna get a Blue Cross report, and then you're also gonna get a HUD report. So we take their data and put it into our own format to begin telling that story of trends, both on enrollment, both on your rolling loss ratios, as well as the high cost claims. Because that's all the data that the markets are gonna ask for if you ever. Self-funded increase. They're gonna wanna have clean data to be able to look at and know that this group is running here, even though their risk score may have shown completely different, 2 years ago.
So I'm gonna use me as an example for that risk thing. I have RA and my doctor has prescribed methotrexate, which is a chemo medication. So that's probably putting me in that high, because it's probably going to have cancer and not.
So, and that's the
I know.
unknowns, that's the unknowns that we don't know
Right.
from just that.
But you'll be able to figure that out
Oh,
with the
yes.
information you get.
Absolutely.
Oh, that's good.
Yeah, so the Blue Insight report will have specific, like Tony said, it will show if there's any high cost claimants.
Mhm.
It will show, it won't say their name, but it'll show like what the diagnosis is, and as long as if it's medical that's high cost, or if it's the pharmacy diagnosis.
Right.
And what the prescription is used for, what.
Oh, that's good, cause I
Yeah.
was wondering
Yeah,
about that when you said what you said earlier. That we don't know what they're diagnosed with, but we see the medication they get. I'm like, that's probably me.
Yes, well, that's, because there's so many medications that
Yes,
they're using for other
different
things,
things.
like even GLP-1s now are
Yes,
using for heart
yes.
stuff and sleep apnea or
Yeah.
whatever, like, so. You can't just assume that somebody's
Right.
taking a medication for that particular original diagnosis that
Right.
it was
Right.
made for, because they're using it for other things.
Yeah.
So, yeah, but no, it will show us like what of that high cost claimant, like what's that main diagnosis or the
Mhm.
highest cost, and then, but it will show truly like. Every month, here's how much you paid in premium, here's how
Right.
much we've paid in claims, and what your loss ratio is. Too, so
That'd be cool.
it will get really nice out, Blue Cross gives a.
Can individuals get that or just the HR one?
On the Blue Insight.
I have not thought mine is.
So
Once you
you,
start getting there.
so you would be able to see as far as, like, on your own explanation benefits on the Blue, you would be able to at least see your claims
Mhm.
and what they've paid and what your
Right.
portion is, right? But yeah, outside of that, it would just be the
Okay.
HR, which even the HR, like, some groups, like,
And I can share it.
Yeah.
you would have the data and it would not be identified from Blue Cross. The
Okay,
HR,
right.
right? So we can get data, like I have a group who has an HRA outside of like the difference card. And they reimburse members who paid over 1,500 up to the $4,000 deductible. Well, they're like, I know people probably used it, so we just sent them, here's the people who met their deductible. So they can match that against people who filed their HRA,
Right.
right? So they can say, hey, you haven't filed for your HRA.
Right.
We
You
budgeted.
put, they budget for it, so they're just trying to be a help,
Right.
right? But they don't have to have access to that data as well. So, yeah.
So the last time I asked you about health initiatives. Like gym memberships and things like that, can you remind me?
Yes, so Blue Cross Blue Shield has a lot of value added services that come from being a member, so they have well on target is what they call it. So they have a whole portal library of all the things you get, all the things you have access to, so that would be something, a place to start. And then a step beyond that is once we get this behind us and some data, we can help groups design programs too. So Tiffany Quarles, you met her. So she's our health and performance coach. And so she can come in and help ideas for you guys too. Like, some of the other cities we work with, they do, gym membership. Program, and they do free health screenings and all sorts of things. So,
And I think it's where you're wanting to go towards it.
Yeah.
We used to have the health.
Well, we used to have the health screens, they would come here and it caught.
A lot, yeah.
Two of my guys were this close to having a stroke. and they
Right,
caught it.
right.
so
And I think, I'll jump in as to say, I think once you have just a little bit of data, the stuff, instead of just a general wellness approach, I think your idea of the physicals on site is perfect, because we always see 2 or 3 people caught with borderline
Right.
stroke level blood pressure, it seems like. But then we're able to start taking a more targeted approach, like, is it hypertension? Is it diabetes? What do we need to be focused on? Is it education? Is it a resource? How do we make it easier for compliance on that to manage those conditions?
And bottom line, if they're healthy, this goes down.
Yep,
yeah, oh, absolutely.
100%.
The healthier our employees are, the better benefits we can offer.
Yeah.
Yeah, and through Blue Cross, there's also, where members can sign up for discounted gym membership.
Yeah.
At a local gym, or they have like a class pass where they can do virtual or something. There's all different kinds of discounts through that, but we have a city, Powell that they partnered with NSU to get, they pay for the monthly membership for the family, every month. So that was by them getting all the savings from changing plans or doing whatever. Well, then the HR has always been like, how can I do more for my employees? So.
Cleveland County has a contract with a local clinic.
Classen Medical Clinic.
And any employee and their family can go see them for anything. Is there any advantage to doing that other than helping your employees out? Does that do anything for them on the back end?
Be a better idea for you all to do it on a self-funded group. Once we look at moving your plan to self-funding, but right now being fully insured, that's just going to be an additional cost.
Okay.
To get the subscription or membership program started.
But a self-funded group, that would take those claims out from the self-funding and
Yeah,
the sniffles and
Yep.
whatever will pay for.
yes,
And then I met somebody, Remedy Health,
yes, Remedy Health,
and I lost her card, so I didn't raise it again.
yeah,
So they're basically the same thing, you pay a monthly prescription, but they're looking for somewhere to go. Here in Chandler, but that'd be about it, 8 months out or
Yeah.
whatever.
Yeah. Yeah, so Remedy Health is kind of gone all over the state, but they're kind of twofold. They do the doctor service right there local, so all the employees get access to it, so that's nice. And then they also, because we all heard about the GLP costs, how it is continuing to rise and more diagnoses are gonna be for GLPs, and they're 1,100 every time an employee uses it, that's a lot. So they also do compounding of those. So instead of paying Blue Cross $1,100 every time an employee uses that, they got the cost down to $500. So it's cutting the GLP cost in half.
Yeah, and they've got some of the compounds like down to 189 to 209 a month.
Yeah, depending on the dosage. So like the highest dosage is in the 400s, and then the lowest is the 200 mark, depending on the composition. But so again, I mean, that is definitely self-funding. It makes so much sense because you're paying your own claims, not, because now Blue Cross is paying your claims and they don't give you a discount on that. So it's just an additional cost, but it's always something to look at. You can do it fully insured. It makes more sense to do it self-funded.
Yeah, it just means you're adding that cost on top of the plan because the carrier doesn't give you a discount.
Right.
For doing those things.
But when you're self-funded, you do get the benefit of the cost reduction. But yeah, that's all the exciting stuff that you get to now think about. You get
Yeah.
to make your own choices and you get to look at your own options and
It's a lot.
your employee population is what we cater all this to. Not just blanket throw something out there
And it's so customizable,
and.
so.
It really is. You can pick and choose every part. And in a year or two, we're going to be, if you look good to go self-funding, we're gonna probably put a different prescription vendor on other than Blue Cross. Cause they're not the cheapest.
Our prescription now is Express Scripts with 2 or 3, so you're saying we'd go to a Blue Cross?
You go to Prime Therapeutics, which is Blue Cross Blue Shield. That's your drug card now, but it's all on your ID card. So. the
There's one
employees-
card for
Yes, the
everything.
employees don't.
Yeah.
Yeah. Yeah, the employees don't even need to know who the name of it, cause it's just on their Blue Cross card.
Okay,
There's my Blue Cross, you know, has medical and pharmacy.
Yeah.
Card, yeah.
that would be wonderful. Everybody loses their prescription cards and then I
Yeah.
can't, it's like cutting teeth, getting new cards and,
Yeah.
or pulling teeth, not cutting teeth, you know.
Yeah.
How do we make sure that we're getting the right bills?
That's a great question.
That is a great question.
I'm looking at you.
Don't look at me.
Yeah.
We kind of question the data we get from them.
Yeah,
So, I mean, that would be a question for OPHW. How do we know these are our claims? I mean, I would ask for a register, a member named register of claims, data service member, to make sure that they're actually your members.
and again, so
Then
the
can we-
member claims what?
It's called just basically a register, like call it like a check register on when they send any demand for payment.
Okay,
You wanna see the full detail. You wanna know the member's name, data service, provider they went to, and the dollar amount at a minimum.
And can we honor that against Blue Cross Blue Shield and say, hey, is this accurate?
Yeah, I mean, I think we probably can. We can get someone at Blues to look at that. I mean,
Yeah, yeah.
between our two people that we work with, they're really close.
Honestly, they might be, being watched now because, you know, the regular Blue Cross is taking over these plans. So if something gets wonky, it's like, well, are you gonna let them look at it? Cause they might see that. So I'm hoping it's not that bad as far as having to worry about taxes.
Any data I get from them, I wonder about.
Yeah,
if you get it, you know.
Right.
well, it's really the scary part because, you know, we know the reporting system really well at Blue Cross, so. Every group that's in there has to be written under a class or a subgroup number. You can pull any report you want by subgroup. So to get a report that would be accurate should be that quick, and I don't understand why it would have to be me. That just makes no sense. So, you know, we looked at your claims that they gave you, they weren't getting you any credit for stop loss when you went through stop loss levels, then they're saying this is how bad and unhealthy you are, but yet that plan is getting paid back money that they're showing in your loss ratio, and they're not giving you credit for it. And then the other thing we didn't see was rebates. They're not reporting the rebates back to you guys
For the prescription.
for all the prescription drugs.
Do we have money in the system? In OPHW, like when we leave, do they owe us anything
Now we're in the roost to them.
because of the special assessment or because of claims?
Because of claims, and then we don't pay our premiums until after the fact.
Right.
So. Like when I pay Marches at the end of the month, it'll be for everything for March.
So if we go with HUB instead of OPH and W, do we pay the premium in arrears or at the beginning of the month?
They bill you ahead of time.
So that means that first month is gonna be double hit.
Yeah, one.
Yeah.
That's true, yeah.
Yeah,
how
so
the
they
actual
basically,
process.
so basically by any submissions by June 10th are billed for July 1, and they want payment on the first of the month. but that's for July.
Because ours comes out of like payroll. We do payroll once a month, which is the last working day of the month, so we would need at least to like the fifth, sixth, seventh of the month. And if we couldn't do that, would we get,
So we would have to just, set it up.
Make
We'd
sure-
have to talk
Make sure.
with Bruce to make sure that if your bill due date matches what.
Yeah.
So it might be that it's like the 15th is, or something. We would just have to make sure they know that because they're starting to assess penalties for late.
Our pay period is the 15th and 15th.
16th to the 15th.
16th
Yeah.
and 15th, and then we pay on the last day. So that would be, we could do 15th and half.
But
Right.
we pay that way, but when we pay insurance and stuff, it's still for the full month. It's
Right.
still March 1 through March 30.
Right. So if we do that, and it's due by the 15th, that would be plenty of time to get.
Yeah.
Yes.
the money.
Yes,
Well, back to changing of the plans, would it be the employee that would get double hit at that
It'd be
first month?
everybody get double hit,
Or would it be the county that gets?
both sides would get hit.
Well, the employee's not paying anything though, right?
Well,
If
some
they
of us
have
are,
to-
some of us are.
I'm not, so I'm fine.
What the-
We might.
Which number?
I would like to- The numbers of the employees that are paid,
Yeah.
I'd like to know the total.
Yeah, that might be hard on
They
them.
can't afford that.
No.
Yeah,
So that's definitely gonna be consideration.
I have that on the census, I can look and see.
And we have,
I think well, I know there's like 8 that have dependent coverage.
8 employees, we could get those names.
that's $8,000.
Mm-hmm.
I'm one of the 8, I'm just saying. Yeah, you're of the 8 or sitting in this room.
We've almost got-
What if I spent up in the last year?
25.
Yeah, 25%.
Yeah, that's too, yeah.
How much is your additional?
About, I gotta think this out because my American Fidelity's in there, it's right at 1,000.
Is that roughly what all?
Mm-hmm.
Yeah, that's pretty close.
Yeah,
Anywhere
might
from
be different.
800 to 1,200, I think. is what
Yeah.
the range is.
Well, that would be sad if you got hit twice.
I know, I wouldn't have a paycheck. Right? I'd work for free that month, right? Yeah. Well, I'm not gonna be in that month from.
Sorry, she can't help it over now.
Yeah. Just kidding.
Sorry, I brought it up.
Yeah.
Well, I'm glad you did.
Yeah, me too.
Things to think about.
Yeah.
Because
Yeah, we could-
if you have the amount, you decide to cover it or.
You would get
Split it
all
out.
employees.
Maybe,
Just
maybe
premiums and problems.
legal cover that.
do that tomorrow.
Those 80.
We can afford to give it 12 employees. But instead of them getting hit twice, we'd have to figure out how to subsidize that.
Mhm.
So OPH&W wanted us to pay ahead
Bidding.
last year. And that was, we ran into this problem. Everybody, the county was gonna get double hit and every employee was gonna get double hit. So I talked them into letting us, as soon as I run payroll, I mail our checks because they agreed that they had it by the 5th of the month. They would never make us do that. So that's why I run payroll 4 days early and go ahead and get the checks out to stop that. So it's gonna have to happen at some point.
Maybe you could like spread it out over 3 months or something, but that's still $330 a month extra.
Well, OPH&W is gonna want their money.
Yeah, all of it.
Yeah, they're not gonna let you say.
They're not gonna do that.
Not meant for the employee, their part.
Yeah. I mean, well, the commissioners would have to pay it and then figure out something. To pay it
What's
back.
OPH gonna do if you just send them 3 payments? I mean,
Mhm.
they don't have a choice.
Well, I mean, you got a good point.
Yeah, Ober's.
They're already behind
Payments,
anyways.
they-
Yeah.
they do it.
Yeah.
I could charge you late fees and benefits, but
Yeah.
And a while ago, I asked what hub stood for, and then I didn't get to listen.
It's not an acronym, it's just a word.
Okay, and how big is the company?
So the way that we're set up is we're part of Hub Mid-America. So our corporate office is in Tulsa and then Kim and I office out of Oklahoma City, but we cover the state. And so we are in Oklahoma, Arkansas, Kansas, and Missouri for Hub Mid-America, but then we have offices all over the nation. So,
just the three of you guys cover that big of an area?
no, you're just meeting your primary service team. We've got a team back in the office taking calls right now for us. No,
And
just.
where's the office?
It's at Chisholm Creek on Memorial and Western, and then yours is by St. Brandon.
I've been to Hub Tulsa.
Mhm.
I've gone, they have lunch and learns and I've been to Hub Tulsa.
Yeah, so we've got two major offices in Oklahoma, Tulsa and Oklahoma City.
On the Oklahoma City team, Caitlin's team, we have 10 team members. So there's 2 account executives. Lily's our like open enrollment coordinator, everything, and then 4 account managers. Ish, a plan admin and an analyst.
And then we have our claims advocate team that helps employees on one-on-one issues.
Yeah, so we have about, in the region here, we have about 80 employees in employee benefits. So,
And the team you'll be working with, we actually have 10, but you're only gonna meet your primary team.
You know, the nice thing's gonna be, is when I call, you can answer my question.
Right.
So since everybody left LPHW, nobody can answer my questions when I call. There's not one person that can answer.
And OPH and W is governed by a board of appointed people.
Yeah, they have a broker on it. So like Hub is a broker, OPH and W has a broker as well. But they didn't invest, I guess, in customer service or anything. For your phone call. Yeah,
That all changed in January.
yeah.
When January left.
On January, yeah.
January was great.
Yeah.
January was amazing.
Yeah. She called me several times and we were
Mhm.
back and forth, and she was, even after 6 o'clock one night, she called me. So sorry, it took me all day, but we don't have that anymore.
Yeah, they were good. She was very good.
And our sister Jennifer with retirees was just spot on. Now you don't do that. That's a sad thing.
You said because I asked you, well, Hub's always looking for good people, but you said she went to a bank or something.
Jennifer did.
Yeah,
Mhm.
well, anything changes. And I'll let her know.
January's taking a year off before she decides what she's
Okay.
gonna do.
She signed, like,
Yeah, they did, both of them.
they only go so far, but.
Yeah.
They can still work with us.
Yeah. January said after, I probably shouldn't say what she said, but she said after the past year, all the changes and everything, that she said mentally exhausted, that it's gonna take her a year to get back right.
Yeah. I can imagine.
And so outside of health plan costs, there's gonna be overrun costs, and whatever we do with our employees, we're looking at. Worst case scenario, out of pocket, 225,000,
Yes.
226,000 on overruns.
And I think you stepped outside when Tony explained that. Tony, will you explain the trickle down effect, like you said, like the first month's gonna be,
so
Yeah.
it's not uncommon at all for us to see Blue Cross Network claims complete with, they only have to have like an 8% IBNR factor. So we ran 8% on the low side. It's probably gonna be closer to 10%. I don't think it will actually hit the 12%. So your pharmacy claims come in really quick. Every 2 weeks, they're being paid. Medical claims are weekly, but they lag a little bit due to filing. So the very first month of the run out is gonna feel like almost like a full month of claims. Second month is gonna feel like maybe a quarter of a month of claims. Third month, it's a trickle. Fourth month, practically non-existent. So they're just gonna complete out.
And when we do your open enrollment meetings, we could tell all employees if you can get your prescriptions filled in early June. And that'll be a big
yeah.
non-hit for July and after.
What did our run out look like last time we changed?
I wasn't here when you changed last time, so I don't know. What was the question?
What did the run out look like last time we changed?
I don't even remember. I can go back in and look. And do you remember what year that was? It's been a while.
I think it was in 19, wasn't it? 19 or 20?
19, because you came in 20.
Yeah. You guys were just going back when I came.
But there would be several claims from that, so it won't be one thing, we'll have to put that together. Anyways, those are just the things we need to really look at.
And here's the thing again, is it gonna be, we gotta figure out a way to get true and accurate numbers. For the runoffs, we gotta figure that, how to get those numbers.
I think they have to provide you a claim report detail of what's being requested.
I would make sure that they give us that and let them know that we will compare it to Blue Cross's data for accuracy. And then run each one back and forth. That way we know we're getting the right one. What else we got?
So when,
Oh, yeah,
Seems like.
well, I was gonna say, once you all kind of talk amongst yourself, digest, think about maybe what type of plans, we can also do all the contribution modeling for you. To show you the, what the cost would be if you did these three plans, what are the savings for these three, so. Kind of let us know direction, we'll put all that together for you too. But we're over 3 months before July, so we have time. So I'd say, we could spend the next month talking about financials and how we want it to look and what plans. And then maybe do open enrollment in May. That way all employees are getting their questions answered, we're helping them walk through all the options, giving them plenty of time to feel comfortable. So, I mean, we have a good timeline right now.
and I was like, we need to discuss it and decide, because open enrollment with OPHW is in April. So there's no reason to do two. I don't wanna do two open enrollments, I will, everyone complain.
I think we also need to
Yeah.
have a decision before April 1st, because we need 3 months.
60-day notice is all that OPHW has to have.
You're sure about that?
That's what the contract says.
Okay,
Per Stacy Bateman, that's what she said.
okay. I heard that it was 90 days, but,
Stacy said 60.
okay. Then by May 1st.
Well. Do we need,
Or do you guys want to pick 3 ways to go, and that what you need to get us that cost analysis, or what you just say we can get it?
Well, no, I said if you kind of think, you've narrowed it down after hearing all these options. And then, we can work up scenarios for you. If you do option A, that has these 3 plans, or option B has these 3 plans, or option C has only 2 plans. So we can work up the financial analysis for you all to look over and things like that.
oh, I was thinking. Stillwater plan for people who live. There,
Okay,
the plan that we have right now, but without the Stillwater option. And then a high deductible plan with an HSA.
okay,
Not the differential card.
I mean, I don't mind adding that, that's the 4th one, I don't
Yeah.
mind adding that. Is that
Okay,
something you're
I got
interested in?
3.
Yeah,
You want,
I am.
I got 3. What, we tell you what 4 again that you want?
The card, the
Card
differential,
differential.
yeah,
Stillwater, not Stillwater, high deductible in your card.
yeah,
Okay.
And do you want the one that's insured Oklahoma qualified as the?
yeah, of course.
yeah, we can just advertise that one, just to.
Yeah.
know that. Yeah. Well, maybe that we don't get membership to it, but at least we have it if we go.
Yeah. Because I think that's where you guys are gonna wanna see the exact number before you make a decision.
Yeah, we need a hard number, and we get it on one of our meetings soon.
So we wanna start with these 4
We'll do it.
and then go from there.
Mhm.
Okay, are you guys okay with that? Start these 4, we'll go from there?
Yes.
The next
We're
meeting
not
is
making that
April
decision, so you're out.
Yeah.
Is the next meeting April 6th?
Yeah, we have.
Think so.
Yeah, I can't find that right now.
Yeah, we can get this,
Tuesday, right?
we can get this all to you before April 6th for sure.
Okay, sounds good.
Yeah.
Well, thanks again for lunch.
Yeah.
Yes,
So
thank
they
you.
said they could get it by April 6th, so want to have it.
Thank you, Dave.
You said they'll pick that for April 6th meeting, I think. So, yeah, we'll get it, no. We can set it.
Yeah.
Okay.
And good result.
Yeah. You
Yeah.
guys know, if you say,
That's what we said.
question,
Yeah.
you know, we're here now.
Okay. Yeah, that way, I'd like to get it done.
This back on the-
It's gonna go to 2.
Oh, do 3.
Cause that requires me to get up early. Tony's gonna come to all 3. Oh, okay, then I'll do 3.
Do that early.
Oh, for you?
We'll start at 10.
Okay. My time early.
Thank you.
Hey,
Thank you, guys.
Appreciate you,
Thank
appreciate
you.
all your time, thanks for
Thank you for
everything.
lunch.
Yeah, you're welcome.
Yes.
Thank you.
Let us know anything you need as we navigate through.
Yeah.
Yes, I didn't hear. Thank you.
I'll make the trip.
Nice to meet you.
Oh, I probably need to tighten it.
Thank you. Thank you.
I'll be talking to you guys soon.
The people that put them together are, I think, are in like a rehabilitation program.
Does anybody want a bottle of water? Anybody want a bottle of water?
That's too healthy. I'm gonna get a Dr. Pepper.
I'm gonna run get a bottle of water.
2.02 more, don't we?
Yep.
I had a monster, you want to? I'll be right back.
There are not too much left.
See.
Put them all in one box. Let's put them all in one box. Doesn't go off at one box.
That's a long one.
We'll go hand it out.
Oh, I text several people trying to get rid of them too. I'll take care of the cookies, don't you guys?
Is there one of those, is it raspberry or whatever? I'll make these fit. I am going to make these fit. Oh, I put them on the side. Amy? Yes. No,
I don't remember what I was gonna say. Let me see the green.
Yeah, pass it back around.
Yeah. Do the chocolate chip cookies have nuts in them?
No. I ate one of them already. I didn't say not.
Didn't that?
There's my bread. Need bread, I need to have bread.
I wondered how much of your sandwich you ate.
Just the meat. You want the bread? Yeah, just the meat. Hey, just the meat and cheese.
I put it on a veggie sub.
You did?
I was like, I could have.
Oh, you could have. I wonder if I need to get. I wonder if I need to get another trash bag. If you remind me, I'll set this out in the lobby because they don't come in here and get this trash at night, so.
I will tell them to.
Okay. That's my shoes, y'all, I promise. They do, they use that baby powder today to go rid of my feet and they still sound that way. I probably won't be wearing these again.
Is that the same shoes you had yesterday?
No.
Okay.
That's what I was
You said
saying.
that about those
Yeah,
two.
that's two new. Everything was I won't be wearing this one.
pairs of shoes, right?
Yeah, 2 pairs of shoes. I had to go shopping and find 2 more.
Put silencers on.
You what?
Put silencers on them.
Yeah. Any other trash? Yeah. No. You can have it better than that. Anybody want another answer? Anybody else, anything else? Thank you. Yeah, are those empty or?
And there's the cookies.
Oh, okay. The chip bag is empty, but,
Leafy, not the other one.
okay, well, I'll take away 2.
You want cookies?
No, y'all, Kathy's taking care of cookies
Taking
there.
care of all those cookies.
Who's Pinchers? Did they-
Ours, mine.
You want them out?
I'm gonna go lady room now, wait.
You really can.
You're taking some cookies, Chesney, is it me?
Gave me that for lunch, so I was like, well, how much I get to spend? She said, no budget, and I was like, okay, so what else could I buy your car?
Could've got barbecue delivered.
Butchers.
Yeah, butcher or even 5-star.
Could have ate that.
I like their smoked chicken. It's good.
Yeah, it's really good, isn't it?
Yeah, it is. Who's Butchers? And, 5 Star. I've only been to Butchers a couple of times.
We were at 5 Star last night, Tuesday night, that's all you can eat ribs.
Ribs.
I don't eat ribs, that does stuff.
I love ribs, but I didn't eat them the last time I was in anything. I ate chicken. I love it.
Alright. Well, shall we get this done?
Yes, please.
2 o'clock.
Not too bad.
No, I can say it's not terrible.
We'll make a motion to, oh, I'm sorry.
All in favor, say aye.
Did we have to stay for the rest of the night?
Calculators,
I was thinking there was something like that.
giving them away.
What that a lot to do,
That's our office.
we don't have to stay and stay in.
You need a calculator, Marlon?
I can't run one of those kind. I just learned if I turn one on my phone over, it does a lot more features.
Yeah.
It's,
Yeah, it's got the full calculator.
yeah, now we do square roots and ratios and
The custom receiving for,
what would you say?
How often do you calculate those?
Me, pretty often.
for
Make a motion for that.
That's not that.
all in favor, say aye. Transfer.
Have two.
Looking for that.
I'll second it.
You sign those two.
I love those. I'm done.
Yeah, the big bag too, one big bag.
If you just set it back by the door, I'll tell them they need to vacuum in. Take out the trash back here. I'll talk to them there and then. They don't check it very expensive, they know we don't need to get back here very, expensive, but I tell them to do.
Oh.
He made the motion to adjourn.
I'll second it.
All in favor, say aye.
All right.
Hey, it's a special meeting, I should be able to say.
It won. Yeah.
Here or